So welcome everybody to this evening's final VRHC21 webinar session on the Victorian Rural Mental Health webinar. My name is Dr. Dan Wilson. I'm a rural generalist in Victoria, and it's my pleasure to welcome all of the attendees this evening. Before we commence the meeting this evening, I'd like to acknowledge the traditional owners of the land in which we're all meeting across Victoria and any others joining from other states in Australia this evening. I'm joining you all from Warrawurrung country in the Grampians region of Victoria, and I pay my respects to elders past, present and emerging of the country in which I'm coming from and the countries of which all of you are coming from. I'd also like to acknowledge any Aboriginal and Torres Strait Islander peoples joining us this evening in the webinar. I'd now like to introduce each of the panellists, and I'll allow the panellists to introduce themselves. First, Dr. Skye Kinder.
Yeah, thanks, Dan. So my name's Skye. I'm a psychiatry registrar in Victoria currently, and also the current vice president of the Rural Doctors Association of Victoria. So it's great to see everyone here this evening. And my interest recently has been thinking about how training could be I suppose changed or developed to better enable registrars like myself to complete as much of our training in rural settings as possible.
Thanks, Dr. Starkinder. Next, we have Dr. Megan Bello.
Hi, thanks, Dan. Hi, everyone. Yeah, my name is Megan. I'm a rural generalist in Kerang, Chuka and Kahuna, and I'm the immediate past president of Rural Doctors Association of Victoria, and I am the president-elect of the Rural Doctors Association of Australia. I do part-time GP work and also GP anaesthetic work, as well as my hospital work as well. And so we'll be coming from that perspective tonight. Thanks.
Thank you, Megan. And finally, Dr. Matt Coleman.
G'day, I'm Matt Coleman. I'm a psychiatrist, so that makes me a partialist amongst all these generalists, but I'm an unashamed ruralist. I'm a regional psychiatrist, clinical director of a regional service in the southern parts of Western Australia in the Great Southern. I'm also a clinical academic in rural and remote mental health and work for the Rural Clinical School of Western Australia, and I'm currently a commissioner with the National Mental Health Commission. I'm currently zooming in from Karratha. Part of my work is to try and undertake what Skye is trying to achieve, which is developing a specialist rural training program, dedicated rural training programs for psychiatry training throughout Australia and New Zealand, and have been the chair of the rural section of psychiatry for the Royal Australian and New Zealand College of Psychiatrists. And one of our main programs recently has been charging up the rural psychiatry generalist pathway throughout Australia.
Thanks very much, Matt. It's a pleasure to have you with us. So this evening, we'll be asking a series of questions to this evening's panellists, and I encourage all attendees to use the Q&A function where you can submit your questions live. Panellists may choose to answer those questions via text, and any particular exciting questions, I'll prompt any of the panellists to answer live if they feel appropriate to do so. So we'll get started on the conversation this evening. So the purpose of this evening is to explore the opportunities for rural mental health change, particularly in the Australian sector, as a consequence of the Victorian Royal Commission findings that have been handed down. We'll also discuss the work that the Royal Australian and New Zealand College of Psychiatrists has been doing to develop a pipeline and specific training pathway for rural psychiatrists in Australia. And we'll, if time permits, touch on the impact in which our current times have for the importance of self-care as healthcare clinicians. So the first question I'll pose to the panellists, I might begin with Dr. Skye Kinder. The findings of the Victorian Royal Commission have been delivered, and there's been significant work done by the Royal Australian and New Zealand College of Psychiatrists. What do you think are some of the improvements that we should be looking forward to in the next few years, specifically in relation to rural mental health?
Yeah, thanks, Dan. It's a great place to start because obviously the Royal Commission into Victoria's mental health system has been pretty significant in a number of ways, certainly in the volume of recommendations that have been handed down. I suppose one of my cautions that I have as the recommendations implemented across the state is that we really need to make sure that in Victoria, regional and rural mental health clinicians and other clinicians who are involved in providing mental health services are actually represented at tables where decisions are being made in terms of the implementation. You know, it's one thing to have great recommendations, but we all know that, you know, great recommendations can go awry if we don't follow that through up until the implementation point. And it's very easy, I think, for some of the recommendations that have been made to get lost in sort of city-centric discussion. But I suppose, you know, some of the things that have been really I think important to have come out of the Royal Commission have been things like the acknowledgement actually that providing a mental health service in the country just costs more than it does to provide a service in the city for a variety of reasons, including, you know, factors relating to the cost of outreach to some of the smaller, you know, rural centres, for example. And hopefully seeing that reflected, you know, in government budgeting as, you know, as we progress forward. I suppose one area that was a little bit underwhelming to me, and, you know, the other panelists might have some thoughts about this as well, is, you know, I do note from the Royal Commission recommendations that there are some areas of rural mental health that it was acknowledged, you know, that there are current deficiencies, but actually the Royal Commission was not able to put forward any suggestions for how to address those deficiencies. And one of those areas, for example, is perinatal mental health services for regional and rural women. The Royal Commission very clearly acknowledges that there is a deficiency of service, but doesn't know how to address it. And I think that's a real challenge going forward.
Thanks very much, Spy. Matt, what is maybe one or two things that you would like to see be transformed from the findings of the Royal Commission and actually be applied?
So I think one of the key issues, and not specifically and necessarily solely from the findings of the Royal Commission, is one of the complexities of our system is that mental health services are often seen as separate to the rest of health services. And I think rather than taking a deficit and disadvantage posture, which is easy to do when thinking about mental health services in rural and remote locations, is actually to start to reconsider our current system in its entirety, rather than siloing mental health off as a different component to the health system. And one of the alternate ways to view mental health in the context of the overall health system, and in particular in a rural and remote setting, is to think about the better integration and regionalisation of health services, in particular secondary health services, with primary care and general practice. And I think this is an area that really the Royal Commission and a lot of the reports that have been undertaken recently don't really put the glue, you know, they don't provide the glue to get those parts of the system working better. One of the things that annoys and frustrates me no end is the fact that the mental health system in and of itself sees itself as separate. And rather than working in a more sort of seamless way with primary care and generalists, we're often missing opportunities. So I think that some of the future really holds. You know, for our college, we've been focusing on how do we improve and enable a system of specialist training for rural and remote psychiatrists, because we're so underrepresented, and you know, the recruitment model of the past has not worked, and nor has telehealth provided the panacea solution that, you know, a lot of people, particularly from capital cities, were hoping it would provide. But in supporting and enabling a specialist training program that is fit for purpose and bespoke according to the needs of rural communities, if we can link that up with the generalist ruralist pathway as well, and improve the access of generalists training in mental health, whether that be through just local collaboration and local mechanisms, all the way through to more formal training processes like advanced skills training in ACRM or RSEGP. And finally, our college is looking at, after some prompting, mind you, from the Commonwealth, of looking at developing a diploma in psychiatry. It's just, and I think, again, the rural context provides awesome examples of having GPOs, GPAs, and GP surgeons, and having those specialist skills as generalists. That why can't we demonstrate in rural and remote situations that you can have GPPs or GP psychiatrists, and Victoria is the perfect and the origin of the phrase from people like Patrick McGorry of the missing middle, and in my mind, particularly in rural settings, there is no missing middle. I think we've got, we haven't got an enabled middle, and the middle being general practitioners who are generalists who choose to and who are enabled to get additional skills in psychiatry and mental health, are perfectly capable and competent with the support of the mental health system to be able to provide an expanded assessment, management, coordination role. It doesn't just require the training, and so you can get your advanced skills training through ACRM, or if you go on to do eventually what will be a GP a psychiatry diploma for generalists, and they'll be able to have experience and training rotations within an expanded psychiatry framework. You also need those enablers for generalists to be able to work in this space, just like GPOs and GPAs who can bill under Medicare and actually have an enterprise that helps them to have a sustained living and a business. And so I think that there are certain levers, both from a training and from a systems perspective, that we're not utilising, and the rural context is really the best context to enable these sorts of initiatives, and the sorts of, so that secondary care can lean into primary care, provide additional supports, but the primary care providers can actually provide enhanced mental health treatment and support mechanisms, and a system that is fit for purpose in rural Victoria, but also in rural Australia. So I'm hoping that out of a lot of these reports, Royal Commissions, discussion papers, that we start to see a rural health systems actually showing how integrated and localised care, when done well and supported and enabled, can really provide enhanced mental health care, so that we're not having to have these expensive systems that are run just like in metropolitan services. So although I hear what Sky's saying, and that these systems will cost more money, hopefully in time we actually get better overall outcomes, better community localised treatment, and generalists playing a key role in that, as well as a locally fit for purpose psychiatry workforce.
Thank you, Matt. Now, Matt's touched on the fact that general practitioners and generalists play a pivotal role in the care of those living with mental health disorders. Megan, with the focus of a GP being particularly the first point of call to develop a mental health care plan or provide first touch point to enter the healthcare system for those with mental health concerns, do you think there's a role for going beyond just that role of the general practitioner psychiatrist? Is there any additional training or skills that could be provided to GP registrars, junior doctors, or even other experienced GPs?
Yeah, thanks, Dan. I think one of the recommendations out of the Royal Commission was that all junior doctors were to have a rotation through psychiatry, which I think is an amazing initiative, because predominantly the only training I had was in medical school, which was fantastic. It was a really good rotation. But but then not until I got into GP training. And even then, it's very much learning on the job. And there is like the certain units that you have to do to make sure that you make the Medicare requirements to be able to train, to be able to bill, with the extra item numbers. But I do feel like there could be more training space. And I think that if you opened up to your junior doctors having to have a rotation, I think we'd have a better understanding of mental health across the board. And so mental health wouldn't feel so segregated from the rest of medicine. And I think that would be a really good starting point, because I think some clinicians shy away from mental health because they don't actually know much about it. And so it's like this can of worms. So if I can avoid it, we'll just, we'll forget about that and we'll go on to something else. I'll just fix your knee or whatever if I'm an orthopedic surgeon. Yeah. So I think that, extra training for junior doctors is a good initiative. Looking at the Royal Commission, I was like Sky, I was quite, underwhelmed in the certain rural recommendations. And I do feel like we need people to be held accountable to make sure that there are changes in the rural and remote setting, and that it's not just lumped with regional, because whilst our regional areas definitely need support, just need to make sure that it filters outwards. I think that'll do.
Thanks, Megan. I'm hearing very strongly the essentially Descartes' duality of mind and body continuing to come through here, that physical medicine exists separate to the medicine of the mind. To extend upon what Megan said there, Sky, as a current psychiatry trainee, what I'm hearing is obviously that the recommendations have been that interns in Victoria must complete a psychiatric rotation. Many colleagues have expressed concerns about the feasibility of implementing that. And secondary to that would be, is that enough to entice people to practice, one, in mental health, and two, do it rurally as well?
Yeah, it's a great question. So, services are ramping up in Victoria for the rollout of mandatory psychiatry rotations from 2022, which is approaching very quickly. And, I think there are a lot of services, to be honest, that I've heard, in our state that are still unsure about exactly what this is going to look like. I know there are some hospitals that are expecting to have a volume of about 70 people that need to rotate through psychiatry departments at their service in 1 year. And that's up from what was previously maybe 2 or 3 people, sometimes 5 or 6 if, they had a particularly robust program. So, we're talking about massive expansion for many, even for our tertiary services, in the city. So I think it's a genuine question. And I think that we all know, if we're being honest with ourselves, that a bad rotation can turn you off a specialty faster than just about anything else. And, I think we just need to be careful. We don't want people coming to psychiatry and either sitting around, not really knowing what their role is, not really knowing what to do, or otherwise actually feeling unsupported and perhaps even, being expected to hold levels of risk or so forth that would be inappropriate. There are a lot of potential pitfalls that I think we need to be really mindful of, and I suspect that some of it is going to be worked out innovatively on the fly. The rotations are going to start coming up, and services, I think, to Matt's point about, local adaptation, are just going to have to locally adapt with the extra junior doctor numbers that they have in their departments. But I think it's important, and I know that Mental Health Reform Victoria have touched on this in some of the documents they've put forward. It's important that we are thinking about how to enhance the experience, not just having the experience, but actually enhancing the experience for the junior doctors, so that people are leaving their internship thinking that mental health is really cool. And even if they don't necessarily want to do psychiatry, thinking maybe, general practice, rural generalism with a mental health focus would be really cool as well.
Yeah, look, one of the I don't know the specifics, but I've certainly been made aware that the mandating of internships is occurring in Victoria, and I guess there's a number of problems with that, because at the moment most intern positions in psychiatry aren't terribly psychiatry related, and so I'm not convinced. I'm never convinced when you have to mandate something that it's going to be a good outcome, because it doesn't talk to quality. It doesn't talk to, planning. It's forcing people, when often forcing anyone to do anything is the antithesis of what we want to do in psychiatry in general, let alone to our poor juniors. And there's significant problems around the way in which you need to supervise interns. And so I think, it would be a much preferred situation where we start to think about PGY1 and PGY2 years rather than just internships, so that you could enable the PGY2 juniors to be able to work in a community less supervised, still supervised, but a little bit more autonomous, so that they get a true high prevalence community outpatient-based experience rather than the inpatient experience. So I must say I'm a little bit worried about the mandating and forcing people out into rural areas, or to, that they during internship. In principle, ensuring that junior doctors have an experience in mental health, I think, is a really solid move. And one of the concerns I've had with the rural generalist pathway is mental health's there, but it's not probably reflective of how much a rural generalist actually sees in psychiatry. So the overall emphasis of having all juniors and generalists having more experience in psychiatry, I think, is a good one. I think it requires a little bit more thinking than just mandating. I understand the emphasis on mandating, but really thinking about having a positive experience and one that is fit for purpose is really the key. And I'm not convinced that inpatient psychiatry is actually reflective of psychiatry at all. Indeed, when you talk to most psychiatrists, it's only about 5% of psychiatrists that work in an inpatient setting. So there's mandating it, rushing it is a little bit problematic, but I think overall I get the emphasis, and I think that it's important that there be consideration of expanded settings for experiences. And you can't expand it for all interns, but RMOs, certainly in country Western Australia, we've got quite sought after RMO positions because we place them in the community doing outpatient high prevalence clinics. And so it just needs to be thought through. Otherwise you end up with a lot of people saying, that was rubbish, I never want to do that again. Yet, as you know, as rural generalists, mental health is a reasonable component of one's working life.
Thanks, Matt. I'd like to hear that you're already innovatively thinking around innovations to PGY1 and 2, and it's certainly in line with the Australian Medical Council's National Intern Review. So possibly those musings that you've shared may actually be in the on the back burner from larger powers that be. And we've got a couple of questions streaming through in the chat and the Q&A. I'd like to turn to a question that's been submitted by Sue Harrison, who says that it seems that specialist psychiatry services in rural areas remain mostly in the domain of international medical graduate psychiatrists, without whom the local system would fail, and led to believe that there's a higher concentration of specialist psychiatrists south of the Yarra compared to even in New York. There's an increasing tendency for private services to cherry pick patients and refuse referrals, obviously exacerbating the current issues within the sector. This is an open question to the panel. Is the college, I presume that's RANCP, doing anything to deal with the maldistribution?
So I might take that one, because this has been a large part of the work that's I've been involved in, and Sky's been one of our trainees. So yes, I think those comments and those observations are absolutely accurate. I always talk about being able to throw a blanket over 85% of psychiatrists in Australia, and it's usually in the well-to-do suburbs in capital cities. Fortunately, I think we're a fellowship of people that generally have a social conscience, and our college is very aware of the maldistribution, but it's to really place the structural issues that are at play. And largely our training system evolved from when there was no training system in Australia, and we imported one from the UK back in the 1950s. And it was very much centred around the tertiary hospitals, siloed subspecialties, and our system has grown out of that and still represents that sort of thinking. And so we are now really pursuing a model that is fit for purpose for rural areas. And I always suggest that it's modest in scale. So it's not going to be for everyone. And again, that's why I'm not into really mandating positions, because we don't want people who are uninterested in doing specialist training in a rural setting. But there are a modest amount of young junior doctors who are out already doing their junior doctor positions in rural locations who would like to stay. What we need to bring, and what we've developed as a rural training pathway roadmap, is to bring the training system to that location and to that trainee. Fortunately, in psychiatry, basically all we need is a pen. So we're not really have to be co-located with a large tertiary centre. Obviously, you need an inpatient experience. But on the whole, psychiatry has been deinstitutionalised, decentralised for at least the past 20 or 30 years. I'm a director of a regional service. We have a child service. We have a adolescent and youth service. We've got an adult community service, and we've got an older adult community service. We've got an inpatient unit. We've got a CL service in our general hospital. So we have the capacity to be able to train someone in a local region who wants to stay there. It's really incumbent upon us as medical educators to enable people to work, live and train in the region that they're wanting to stay in. And if you can enable a young doctor who's interested in psychiatry to be able to get a mortgage, find a partner, have children in a rural location, guess where they're going to stay? And so it's really about bringing the training to people who want to be in the bush, rather than making sure that people in the bush have to go to the city. So we're now, currently our college has endorsed that system. We now need to put some rubber on the road and implement it in each jurisdiction so that we can start to have a system where a junior doctor who's in the country and says, I would like to really stay here. Do I want to sign up for a metro system, or can I tick the box for the rural training pathway and take it from there? Can I just quickly also add the comment around cherry picking? I think that's 100% accurate. And that just like in other specialties, if we've got specialists, they need to be seeing the more complex and difficult to treat patients, and part of that conversation that Pat McGorry talks about is the missing middle. I don't think it's missing. I think a lot of high prevalence cases with a little bit of training and a little bit of extra support by specialists leaning into primary care, general practitioners, given the opportunity, given the training, given the Medicare rebates and enabling general practice is not very popular discussion amongst my colleagues. They fear GPs are going to take over their businesses, but ultimately we want psychiatrists to be seeing that the harder end, and considering they've had additional training, and for primary care clinicians, both your generalists, but your generalist who's done some specific mental health training, to be able to see those high prevalence cases, and so that there's less cherry picking. I can't agree with you more. There's lots of politics in that, but hopefully that's where we'll get in the future. And I think rural is the place to demonstrate the concept, to prove the concept.
Thanks, Matt. I'd like to move tonight's conversation along a similar stream to a comment from Mari, who's got a question focused around the COVID-19 pandemic. So Mari is interested to hear whether the panellists are seeing particular mental health issues in rural and regional areas, so especially in the areas of Victoria that have experienced lockdown. Megan, I'd like to ask you, what's been your experience of COVID-19 pandemic, and particularly its impacts on your rural patients?
So definitely last year in our second extended lockdown, I felt like the anxiety in the community was palpable. It was quite significant. At that time, I was actually still on maternity leave and didn't come back to GP till September last year. So my view is probably a little bit skewed, but definitely there was definitely a lot of anxiety. Patients were coming in for the extended mental health visits, so that was good that that was put into play. This time round, having just gone through our 5th lockdown, I kind of feel like whether or not we're adapting to that way of life, essentially, but it's still very stressful. And it's quite stressful to see that, you know, certain businesses have shut, and that, you know, the stress around homeschooling. The other thing that COVID has really done for rural Victoria is that our house prices have gone through the roof. You can't rent a house in Echuca. So, you know, for those people that are on you know, very tight budgets, and, you know, they may well be forced out of their housing if the rental market goes up, you know, it's not have a job, it's actually quite significant. So I feel like there's probably more that needs to be done, and it needs to be incumbent of everything that makes someone's well-being, so to address all those issues. Otherwise, yeah, I don't think we're going to get anywhere.
Thanks, Megan. Certainly hearing the social determinants of health come there through strongly. Sky, you work across both inpatient, outpatient and other settings. What's been your experience of COVID-19 pandemic on the mental health of your patients?
I think, I mean, certainly, you know, to reflect Megan's sentiments, you know, that sort of general palpable anxiety very much in the community. But I think one thing, you know, that has been brought to my awareness several times in terms of regional and rural patients has actually been the unique disadvantage that our regional and rural young people, so children and adolescents, have been at when it comes to accessing services during COVID. I know that across the state, we've seen quite significant spikes in young people requiring child and adolescent mental health specialist services as a result of the stress of the lockdowns, and particularly our extremely long lockdown last year, where we saw, you know, rates of self-harm actually increase quite significantly in that population. But, you know, one of the challenges for young people in regional and rural settings in Victoria is that accessing an inpatient mental health bed as a young person outside of the city is almost impossible. And so, you know, not only were we sort of experiencing this challenge for our young people across the board, but then our young people from the regions were having to travel to Melbourne and be separated from their support networks, plus having issues with, you know, visitors on the ward because of COVID and all of those sorts of things, and really being quite isolated in the city, I think, in, you know, in a number of respects. And you know, that's something that we really need to think about going forward with the ongoing impacts of lockdown, you know, when it comes to our young people.
Matt, did you have a brief comment to make on the same question?
Oh yeah, the stats back up both what Megan and Sky said, and you know, people presenting, particularly young people presenting with eating disorders across Australia has gone up 100%. You know, which is pretty significant. You know, if you were to look at any other health condition. And on the whole, mental health service delivery and the requirements and the amount of referrals, you know, if you sort of generalise them across the country, have gone up 30 to 40%. So there's been a significant response, and you know, I think the prophecies of having a dual pandemic and there being a follow-up mental health pandemic, you know, initially were alarmist, and I think we need to be cautious, but there's certainly been a significant increase across the board, but in particular regions that have been affected by lockdowns because of all those social determinants. You know, there's losing your job, having housing issues, lack of social isolation, and a lack of social contacts and additional and supports inevitably creates stress and strain on people's mental states, and we've seen that that's come to bear. And I guess over the next couple of years we'll see potentially an ongoing tale of increasing mental health presentations in all settings.
Not only have our patients been struggling, but indeed our doctors are struggling as well. Not only, even before the pandemic, there's been increased levels of stress among my colleagues that I've been working with. And given throughout the pandemic, there have been a significant number of delays to examinations, debacles through vaccination rollout for both trainees and established professionals. It really started to highlight the importance of doctors looking after their own well-being. How important do you think that is, Skye? And is there anything that you do particularly to look after your well-being?
Yeah, I think it's a great point, Dan. You know, as we all know, you know, the workforce, particularly in Victoria, across, you know, many sectors, is feeling a bit on the burnt out side of things. It would probably be fair to say, and you know, the burden of that is obviously disproportionately felt by, you know, people who are servicing, you know, rural and regional centres, particularly our rural centres, of course. I think, you know, it's hard, isn't it? Because I suppose as a trainee, you try to hold on to as many things that you can control as possible in such an uncontrollable situation. But, you know, all of the colleges, and ours is certainly included, you know, are struggling in terms of fellowship exams, for example. And, you know, the impact that has on the individual is obviously enormous, but also then the impacts for the workforce. You know, we normally have you know, several hundred people sitting our exams every year, and you know, that got dropped down to sort of 40 you know, in one sitting at one stage, which is a pretty significant decrease in people who might be potentially able to fellow and then contribute to the psychiatric workforce in one way or another. I suppose, you know, for me, I think it's about collegiality. I think at the start of the pandemic, you know, I remember a lot of my psychiatry registrar colleagues and even some of our consultants sort of felt a bit helpless as to what we could do, because we didn't really feel like we were on the front line per se. And that's changed over time, actually, with the increase in mental health presentations that we're seeing. We sort of, I think, very much, you know, certainly in our trainee circles in Victoria, would feel much more on the front line than we did initially. And it's really the collegiality, I think, that's helping everyone to get through. You know, if you're feeling burnt out, take a mental health day. Sort of an attitude is really important. Looking out for each other as much as we can.
Thanks, Skye. Same question to you, Megan. What do you do to look after your mental health?
Yeah, thanks, Dan. I think just over the last 18 months across the board, everyone's extremely tired. I mean, rural doctors generally, before the pandemic, before the bushfires, were pretty, you know, very busy, and some of us probably were already burnt out at that point. So it is really important to look after your own mental health. I guess the other thing that is also lacking is where I generally get a good sense of helps me feel better about my job and everything, is getting to go to conferences and mingle with my peers and have that debrief with, you know, other colleagues essentially, and just have a good time. So I think the fact that hasn't happened for a lot of us this year, I think for the last 18 months, I think that's been quite difficult. Well, this week I was meant to actually be in a Queensland holiday. Instead, I'm in Victorian lockdown. So just trying to physically get away from your community, which would generally be a good time out where people can't contact you, is getting harder. So that's one of my normal things that I would like to do. So that's hasn't gone so well, but exercise via Zoom with a toddler in the room has been good this week. So, you know, I did my click and collect with my Kmart exercise weights and did a few Zoom sessions this week. And I must admit, you know, that actually was quite helpful. So, and I think trying to plan the next holiday and maybe lower my expectations and just stay within Victoria might be good. And yeah, but I think just looking out for your colleagues is really important, and having those regular phone conversations with the people that you can is really, really important. And when you can physically catch up for a coffee or a meal, then do it.
Thanks, Megan. I'd like to address something that I've made an observation in the attendee list tonight. It's predominated by female representation here this evening. Megan, as a frontline worker working with patients with mental health conditions, do you experience as a female GP that you feel that you bear the brunt of providing care to with people living with mental health conditions as opposed to your counterparts?
So my GP practice that I work in, I am the only female GP at this point. But if you want to come to Kerrang and join me, please feel free to do so. Male or female, by the way. We've also got a nurse practitioner who also works in our practice, and she also works up at the local school, high school, which is a really good program. But do I feel the brunt of it? Some days, yes, I do. And so in the sense that I do a fair bit of mental health, not necessarily by choice. I just I feel like certain personalities attract certain patients, but that happens across the board with lots of different illnesses as well. I do find that maybe because I give my patients a little bit more time, that sometimes that extra 5 minutes in the door then allows them to open the can of worms of other stuff, which to me feels like I'm doing good medicine, that I'm getting the whole story out. So yeah, I mean, generally my appointments can blow out to 20 minutes. Sometimes I think my average consult would be around the 16-minute mark, 18-minute mark. When I was studying for my RSCGP exams and trying to get it under 6 minutes for your OSCE, that was actually really helpful. But yeah, generally that leads to having more patience, and also it's actually sometimes got to the point that depending on certain patients and knowing what they're in for, I will limit the amount of people that I see that I know, so that I'm limiting how many mental health patients I'm seeing per day, because if my day is half of mental health, then I am drained by the end of the day and I don't have much to give. And so that's a bit about self-care, but then I know that I've got to manage that so that I can give the best to my patients.
Thanks, Megan. Matt or Sky, any reflections on the observation that many female healthcare practitioners, I guess, colloquially carry the load in terms of the lion's share of providing a lot of mental health care?
This is kind of tiger territory, isn't it? For me as a bloke. Let's be clear, because it's the same in the College of Psychiatrists. You know, we're well represented by women in psychiatry, and we're all the better for it, to be honest. I think that the nature of the complexity and the affective load of people presenting with mental health problems, just by the sheer numbers, is managed better by women. It's a generalisation, but I think it's an important generalisation. And I need to be careful what I say here, but in the end, I think that it's no surprise that patients also look to predominantly female clinicians for help when they have mental health problems, and I think that it speaks volumes in itself, really. And so it doesn't surprise me that most of the attendees here tonight are women.
Thanks, Matt. Well done, not sticking your foot in it there. I do want to have the opportunity to get to one of our attendees' questions, which is returning back to looking at potential reform within the Victorian planning sector for potentially looking at GP psychiatrists or GPs that are able to provide advanced skills in psychiatry. Emma asks, I've often wondered how those rural generalists who choose mental health as an advanced skill are able to bill. She's obviously clearly conscious here of the restrictions in Medicare. I'd love to hear that RGs could bill similarly to a psychiatrist for a longer appointment. Otherwise, I can imagine that some GPs would be under pressure to have shorter or rushed or even less effective sessions, which would be really disappointing. Is this the current situation? That's an open question to the panel.
So there's I don't know what level of practice the person that's asking the question, but if you do the mental health skills training workshop, you can bill at a slightly higher level. I think it's worth $20 extra for a mental health treatment plan. The next step up for rural generalists is, according to Medicare, is you can become an FPS, which is focused psychological services, and that's providing CBT and other regulated forms of psychological interventions, and they're rebatable for GPs. But I agree, they're nowhere in the realms of psychiatrists. I think it's I'll have to out myself here. I think that it's inequitable, unfair, and it's part of the problem, particularly in rural and remote Australia, why there's a Medicare underspend when it comes to the population for mental health, and there's a predominance of prescribing over access to psychological care. I can't see, and I'm certainly an advocate for pushing the Commonwealth to look at expanding the rebatable services that GPs should be able to bill. I think that is coming, but there's a lot of water that needs to go under the bridge, and political manoeuvring, for want of better words. I think that a lot of my colleagues would find this conversation rather confronting and feel like their patch is being encroached upon. And that's why I'm definitely an advocate for pushing for the rural generalist pathway to incorporate more psychiatry, more mental health, and to use it as an environment and an area where we can push for reform, because there is a lack of specialist, both psychology and psychiatry workforce in rural Australia. And if we can then convince the Commonwealth without feeling like that we're going to have 15,000 GPs come out of metropolitan areas all of a sudden billing Medicare at higher rates, that we can actually have a fit for purpose a diploma in psychiatry, that there are areas of need in rural and remote Australia. We can start to refer to it as the missing middle. We can start to look at rural generalists being able to bill specifically for providing enhanced psychiatric care by rural generalists. I think that's the way forward, but there's a lot of work to be done to get there. So as it stands, the increased mental health MHST, I can't remember what it stands for, and there's the FPS, the focused psychological services that GPs can provide. You can bill additionally from a general practice point of view, but there's still a way to go, and that's part of the problem.
Thank you, Matt. Guy or Megan, did you have a brief comment to make on Emma's question?
Yeah, then I'll comment. So I think, there definitely does need to be some reform, and I think if we're going to have rural generalists who had an advanced skill in mental health, that they should be remunerated in the same capacity that it is if you're a GP obstetrician or GP anaesthetist, because that they are doing the work, and it's definitely warranted. And I take my hat off to anyone who could do that as an advanced skill 24/7, even GPs that work 5 days a week in GP land. That's one of the reasons why I'm a rural generalist and I do my anaesthetics, is because I need the combination. I can't always do that work, if that makes sense. So I think that there definitely needs to be change of remuneration, most definitely, to enable this. But also what I'd love to see is psychology that is tangible and that doesn't cost an arm and a leg for our rural Australians, because it, just trying to get a psychology appointment can be really difficult. And then, to be out of pocket for like $150 for some families is just unquestionable. So, to be able to have that sort of service would be amazing. And also, I think in the last 5 years, there has been a real change with telehealth. And so being able to get a once-off psychiatrist review has been really good. But trying to follow up, when you've got that trickier patient that, like Dr. Harrison wrote in the comments, sometimes you just want your hand held in those trickier bits, that's what would really help. Also, sorry, I've just lost my point, but yeah, just being able to get that psychology help for our patients and not necessarily always being over telehealth, because I have had some patients that don't want to use telehealth as well. So I think that's important to note, that being in person and being with someone is really important.
I think also, if I could just add, I suppose hearing yourself, Megan, and Matt talk, the thing that comes to my mind as well is how, as a medical profession or a broader health profession, we value different types of work, right? And, procedural work is valued in a different way than mental health work, even though, as everybody has sort of touched on in this conversation, working, with patients who have a lived experience of mental illness can be extremely personally challenging and actually exhausting in its own right, even though it's not a procedural specialty area. And I suppose it comes back to some of these issues that we have around how psychiatry fits into the medical model, and should it even, to Matt's point earlier, mental health has been deinstitutionalized. Should we even still be chained to this, form of medical, specialist subspecialty sandstone model that we have in the first place? But I think, what it comes down to for me is, how do we actually value the work that's happening, and I think there's an argument to be made that the work has just continued to be within our profession and possibly to some extent in the wider community undervalued in comparison to other aspects of medical care.
There's much in a name. Maybe we need to be considering interventional or procedural psychiatry.
No, Megan? We'll have as many rural psychiatrists as possible. Just bring them my way. That'd be great. Give us more. Just touching on in the chat, the item numbers for GPs to bill, it's actually, you get more for just a normal 36 time length GP consult than you do for an actual mental health consult. And so that does, that in itself is a reflection of where mental health sits according to Medicare, and it's suboptimal.
Absolutely. Thank you for raising that, Megan. Just in the interest of time, I'd now like to turn to each of the panelists to provide a concluding remark on their reflections from this evening that could cover any of the topics that are covered this evening. I'll start with you, Matt, a concluding reflection.
Oh dear, I was sniggering to myself of wouldn't it be a lovely reform just to remove 10% from all procedures and funnel that into general practice. Anyway, that's a fancy and a wish, but I just going back to I guess my concluding comment was just about self-care, because I think it's a really important point to end on, at least from my perspective. One of the important things that I think, and Megan touched on it, is having variability in your work. And one thing that COVID has taught me is that sometimes I can take on more roles. I have to reduce, obviously, just from a time point of view. But if I'm doing multiple things, actually the spice in life keeps me well and keeps me fresh. So I think sometimes taking on additional roles and reducing the amount of time you spend on other things so that you're in multiple places, it keeps you well and healthy. And the other thing that I've been doing and really paying attention to is I'm going and doing small local trips that I would never have ever done before. And even if it means going to the next town and getting an Airbnb for the weekend, which I would never do because I'm too busy thinking about going to conferences. Previously too busy thinking about going to conferences and holidays over in Queensland or going overseas. I'm now actually exploring my local area in much greater detail and depth, and going mountain biking with the kids and doing these sorts of activities, and staying in the next town just to get off my farm. Those things have really kept me in good stead, and I don't have to worry so much about the lockdowns. So they're the things that I'd get people to consider, in the time going forward, to keep their mental health ticking along.
Keep it local, I like it. Megan, any single final reflection from you?
I just want to see more rural doctors in general. That's what I want. I want, right doctor, right time, right community, and I want us all to work together. And it doesn't matter what specialty it is, but I just want more rural doctors.
Well said. No more of this patch stealing business. Guy, final reflection from yourself as well.
Yeah, thanks, Dan. To be honest, my final reflection was similar to Megan's in so far as, what I'd really love to see going forward is just more collaboration. I think this, the interspecialty rivalries that occur are just so unhelpful for rural communities and for our patients. And I feel very proud that the Rural Doctors Association, particularly the Rural Doctors Association of Australia, has really embraced, this movement of collaboration and collegiality, and this understanding that actually, generalists and specialists can not only coexist, but actually, dare I say, support each other to actually be a genuine collaborative, fit for purpose workforce, that meets the needs of local communities and offers people variety, as well. Not everyone has to be a generalist, and not everyone has to be a specialist, and there's a way to come together in the middle. And I hope that events like this continue to foster those sorts of conversations.
What a perfect way to end this evening's webinar, which brings us back to our VRHC21 theme, which was actually ruralists together. So moving away from that division between generalists and specialists, and in fact, we are all a part of a collaborative community. I'd like to thank all of the panelists and attendees for joining us this evening in our final session for VRHC21 speaker series. A virtual off-camera round of applause for Drs. Skye Kinder, Megan Bello and Matt Coleman. Thanks to everyone that's participated in all of the virtual speaker series and the different panels. All of the sessions are available on the Rural Doctors Australia Victoria website through the events page. And if you've missed one or would like to relive one of those sessions, I would like to inform all of the attendees this evening that plans are certainly underway to hopefully hold the Victorian Royal Health Conference 22 in Bendigo in May of 2022. Pending social circumstances, I'm really looking forward to that, hopefully being a face-to-face event. As a final note, I'd like to announce that the Australian General Practice Training 2022 final round applications for the Australian College of Rural Remote Medicine open on the 7th of August and close on the 30th of August, and the Royal Australian College of General Practitioners open from the 30th of August. And I encourage any of those attendees interested in more information to check their websites for the full details. Good night, and thank you for attending this evening.